The CAPTIVATE is a study that has been performed in order to assess the combination of two drugs, the BTK inhibitor, Ibrutinib, in combination with the BCL2 inhibitor, venetoclax. So this study was based on some preclinical experiments that clearly showed that these two different drugs have a complementary mechanism of action that will allow to act in CLL in the different compartments of CLL, not only in peripheral blood, but also in the lymph nodes and in the bone marrow. So therefore, this study was performed in combination with these two drugs, starting with 3 cycles with Ibrutinib at the beginning, and then followed by the combination of Ibrutinib plus venetoclax given for 12 cycles, and to stop therapy in these patients after 15 cycles in total of these after giving these two drugs. These were we included patients, previously untreated patients with CLL younger than 70 and independent if they have high-risk features as for example mutated IgG3 genes or p53 aberrations. So we have this population included in this trial. So this is a phase 2 trial in which in this fixed duration cohort, by giving 15 cycles of therapy with this combination, we stop therapy, and then we look at the primary endpoint of the study, which was the rates of complete response achieved after giving this combination. There was another cohort in which that was performed according to the MRD status, in which the patients were randomized according to the MRD status after these 15 cycles. And according to that, patients who had unconfirmed minimal residual disease undetectable or confirmed undetectable minimal residual disease, they were receiving different strategies. But what we are focusing now today, and that has been presented at EHA this year, has been the fixed duration cohort in which we combine the two drugs given for a total of 15 cycles. Well, the key results of this study, so if we look at the primary analysis that was published, that was presented last year, with 2 years of follow-up, we observed that there was a high complete response rate by giving this combination, which was near 60%, independent of the high-risk features if the patient has mutated IgG3 genes or p53 aberrations. And what we have confirmed with one more year of follow-up, so which means 2 years after stopping this combination of therapy, is that the patients, the CR rate, the complete remission rate improves a little bit and is independent of these high-risk features that are present in patients with CLL, such as mutated IgG3 genes and p53 aberrations. And what is more important is that the response was maintained even after 1 more year of follow-up. This is translated in a longer progression-free survival, and clearly, we can see that independent of the high-risk features, so we are seeing that the PFS at 36 months is more than 85% of the patients are free of progression, and even in patients with unmutated IgG3 genes could do very well under this combination, and slightly worse in those patients with p53 aberrations. So the main message is that with a time-limited therapy with these two drugs, so we are able to improve clearly the quality of the remission, and that allows to stop therapy in this population, and that we are seeing a maintained benefit after stopping the combination after 2 years. The patients are still, most of them are free of progression, and obviously they are still alive. Well, this combination has still not approved yet, but once approved, I think this is a great combination in the frontline setting in order to treat CLL patients independent of the high-risk features with a kind of a chemo-free regimen, taking advantage of these two drugs, which allows to act not only in peripheral blood, as we have seen, but also at the lymph node sites and also in the bone marrow. So all in all, this is given us a strategy, a time-limited therapy strategy for CLL patients in the frontline setting in a young CLL population, and including patients with high-risk features such as those with mutated GHB genes, and also the population with P53 aberrations may also benefit from this combination, even given this treatment just only for a year. In terms of the safety profile, so I must say that this combination is very well tolerated, that since we are talking about stopping therapy, so we are not seeing a high frequency of adverse events, and probably what is more important is that those patients who have already progressed after time-limited therapy with Ibrutinib plus venetoclax, so the option of retreating these patients with a BTK inhibitor seems to be very promising. And although there are few patients who have already progressed and require therapy, in this final analysis we have only 12 patients who received who were retreated with Ibrutinib. So what we are seeing, although the follow-up is still short, is that these patients respond again to a retreatment with the BTK inhibitor given as monotherapy. So all in all, this is giving us the view that by starting treating CLL patients with a time-limited therapy, we probably can avoid mechanisms of resistance, and then we have the option, once they progress, to retreat again with the same combination or with any of the drugs that we have used in the frontline setting.